resuscitation to decrease the serum lactate level. Again, I told you, look at the elevated lactate level with a word of caution. And also a new addition is to suggest using the capillary refill time. And this is something very practical and useful in the, especially in resource limited settings to guide resuscitation. And this has been incorporated in the 2021 iteration of the surviving sepsis guidelines. Mean arterial pressure, and they recommend a mean arterial pressure target of 65. Again, it's very important to remember that this is not a general target. It is only for initial resuscitation, because again, the mean arterial pressure may need to be individualized for different patients, but it's just a starting point. So it's initial management and not throughout that you have to maintain a 65 MAP as most people imagine. And capillary refill time, the inclusion came after this very famous study, as you all know, the Andromeda shock study, which is a randomized controlled trial, which looked at the effect of resuscitation strategy targeting peripheral perfusion versus serum lactate. And the primary outcome was the 28-day mortality. Now, this shock study, I won't go into details, but what they looked at what they did find that at day 3, the capillary refill time had significantly less organ dysfunction, though the primary outcome, there wasn't any significant difference between the two groups, as the 28-day mortality did not reach significant, statistical significance. But I can say that despite the absence of a clear effect on mortality, using capillary refill time during resuscitation and has physiological plausibility, and also it's easily performed, it's non-invasive, and it doesn't involve costs. The only limitations about this is standardization, because we still don't have a standardized way to do this. One of the benefits is that capillary refill time, unlike lactates, which take some time to clear, this is more real time. But the challenges, of course, is that we need standardization. And of course, there are some limitations with the use of capillary refill time. But otherwise, it's a very practical thing to do in especially in resource limited settings. So one would say that even if you're not a resource limited setting, it's useful today to use capillary refill time in conjunction with your serum lactate levels. And this can be easily done at the bedside, and there are various techniques to do this. Coming to the other things about initial resuscitation, a thing I like very much is to use dynamic rather than static variables to assess fluid responsiveness, and various dynamic parameters like passive leg raising, stroke volume variation, etc., have been recommended in this iteration and during initial resuscitation. Now, one of the things that is a down regulation is the earlier recommendation said 30 mils, and this was a suggestion in the current guidelines, whereas it was a recommendation. So they've actually downgraded it because this was quite controversial because of a large volume of fluid that was given. You can't have a one-size-fits approach for everyone. And again, within 3 hours. So a more practical approach would be perhaps to give 10 mils per kg of fluids to the patient, assess whether the patient is fluid responsive or not, and then decide whether to give the subsequent volume of fluid. Perhaps the patient might need 50 mils per kg of fluid, or perhaps this patient may not take it well if he has ARDS or a very bad heart. So it's a good practice perhaps to individualize this by doing an assessment after giving the initial resuscitation and giving a more guarded volume of fluid rather than giving 30 ml per kg, a one size fits all. Fluid responsiveness has been emphasized using dynamic parameters. And what is fluid responsiveness? Essentially, it is a state when administration of fluid will lead to improvement in the stroke volume and hence the cardiac output. So today, we're not just interested in whether the patient can take in more fluid or we can optimize the preload, but whether giving a certain amount of fluid can increase the cardiac output, because if it doesn't increase the cardiac output, there's going to be no benefit and you might actually produce harm to the fluid. So determining which patient is fluid responsive is really a challenge in the intensive care unit. Like, we don't want to give excess fluid and push the patient to pulmonary edema, but at the same time, we want to give enough fluid so we restore organ perfusion. So when we ask the question that should I give more fluids, what we really want to know is, will the cardiac output increase? And this is really a challenge. And this is why this is one of the most controversial statements in the Surviving Sepsis Campaign guidelines, to give a 30 ml per kg bolus to all comers. Now, I'll just elicit this very quickly by a short case. And this is a patient who's come for an emergency surgery. And this is a real case, a case of CA colon, 55-year-old male patient, presents with intestinal perforation. He's had an inferior wall MI 1 year back. His ejection fraction is 40%. He's febrile. He's got an elevated white cell count. Respiratory rate is 36. He's got a tense distended abdomen. This is obviously an intestinal perforation. And this patient was intubated, ventilated. He's on high FiO2, receiving high PEEP. Now, already in the emergency department, 3 liters of fluid have been given to this patient. He's tachycardic. He's got low blood pressure. A central line has been inserted, and his CVP is 14. And lactates are 4.5. Now, this is typically the kind of patient that presents to our unit, intensive care units, who have been resuscitated like this in the emergency department. Now, when you look at this kind of patient, it's really a dilemma as to whether you should give more fluid or not to this kind of patient. Now, if you ask yourself objectively, should we give him more fluid? Are there reasons to give him fluid? Yes, this is likely to be intra-abdominal sepsis. And we know there's relative hypovolemia, there's sequestration of fluid into the bowel. He is persistently tachycardic and he has high lactate. On the other side, there are reasons not to give him fluid. If you look at the CVP, it's very high. He's already received 3 liters of fluid, and he also has this history of the previous myocardial infarction. So this is the kind of dilemma that we're faced with giving fluids in the intensive care unit. And that is why a more practical approach is to look at dynamic indices of fluid responsiveness and assess whether the patient is fluid responsive or not, rather than give a fixed amount of fluid to all patients. Now, when we give fluid to a patient, we presume that they're on the steep part, or we assume that they're on the steep part of the Frank-Starling curve. I'm sure you've seen this graph several times before, which means that by giving a certain amount of cardiac preload, you can increase the stroke volume. But it's important to remember that you don't have one Frank-Starling curve, and there could be a family of curves. And the same patient in whom you give a certain amount of fluid, after you give a certain amount of fluid, this patient may be on the flat part of the Frank-Starling curve, and giving more fluid may not be able to increase the stroke volume as much. Or you might have someone with cardiac dysfunction who may get the same amount of fluid, but may not have as much increase in stroke volume. And that is why the static parameters of fluid responsiveness do not help you assess whether your patient is fluid responsive or not, and you need the more dynamic parameters. And this has been recommended now in the surviving sepsis guidelines. And most of these parameters are based on heart-lung interactions, have certain limitations, but you have the passive leg raising test that's also recommended by the surviving sepsis campaign guideline that is independent of heart-lung interactions and can help overcome the limitations of most of the currently recommended tests for fluid responsiveness. So this is perhaps one part of the surviving sepsis guidelines that needs a more, more fine-tuning to a more individualized approach that can be, matched depending upon the patient settings. So really, when we ask whether we should give fluid or not to a patient in septic shock, the most important thing is there acute circulatory failure? And if the patient is in shock, hypotension, tachycardia, elevated lactates, increased capillary refill time, yes, of course. And you need to see whether the patient is fluid responsive as recommended. And even if the patient is fluid responsive, you shouldn't give fluid unless if there is any major risk of giving fluid. So if your answer is yes to all these 3 points, only then should you go ahead and give fluid to these patients. Now, what about the type of fluid? Now, the recommendation for the type, of course, there's good evidence that you should use crystalloids over colloids today. Another recommendation, it's weak, is using balanced crystalloids instead of normal saline. I think this is quite a strong recommendation actually to say just to use balance, but important to remember that even ringer lactate is a balanced crystalloid, right? So I don't think we can completely throw normal saline out of the window. It's again a weak recommendation, as I mentioned. And they suggest using albumin in patients who receive large volumes of crystalloid over using crystalloids alone. And when you're giving large, and this is especially in patients who have very leaky capillaries, as you see in patients with septic shock, and you're giving loads and loads of fluid, the blood pressure comes up, and again, it goes down after you stop giving fluid. In these kind of patients, perhaps there's a good role for recommendation for giving albumin, and also a recommendation against using starches, and we have good data for that. And they also suggest against using gelatin for resuscitation. What about vasoactive drugs? And of course, norepinephrine is the first, agent of choice. They've suggested using vasopressin instead of escalating doses of norepinephrine. And when inadequate MAP levels are not there, despite epinephrine and vasopressin, they suggest that you could add on epinephrine. And they, of course, have suggested against the use of terlipressin that was, suggested in the earlier recommendations. So regarding inotropes, now this is very important that in a patient, just having acute circulatory failure is not enough. A lot of people used to start dobutamine just to improve the microcirculation, improve the peripheral perfusion. But you could start this only if you have septic shock and cardiac dysfunction and persistent hypoperfusion despite adequate. So you've given a certain amount of fluid, you have cardiac dysfunction, you need to have cardiac dysfunction to start an inotropic agent. So cardiac dysfunction with persistent perfusion, hypoperfusion despite adequate volume status, and arterial blood pressure. So this is suggest, and most importantly, they have suggested against using levosimendan, which was recommended in though it's a weak recommendation, it was there in the earlier guidelines. Now, monitoring and intravenous access. Now, this is very important, and especially from a resource-limited perspective, because they've talked, it's not possible to have an arterial line put in very early, or also to have central lines put in, not only from a resource-limited perspective, but also the expertise may not be available. So they have suggested that invasive monitoring of arterial blood pressure over non-invasive as soon as possible, if the resources are available. Okay, so you could continue your monitoring non-invasively if you don't have an arterial line, central line, and you don't have the expertise to do this. And they have also suggested starting vasopressors peripherally. Okay, so earlier it used to be you can't start a vasopressor unless you have a central line, but do not delay your vasopressor therapy, until you have a central line in, or you have someone with the expertise who can put that. And the important thing is to avoid delaying the initial, administration till the central line is put in. So I think this is though it's a weak recommendation, is a very good condition, and there's a good rationale for that. We don't have randomized controlled trials that compare central and peripheral catheters for initial vasopressors. Very good trials are lacking to make any conclusive evidence about that. I won't talk much about the antibiotic timing because one of our speakers is going to talk about that, but they have given a distinction about shock is present and shock is absent, and it's not necessary to immediately start antimicrobial agents within the first hour, as was earlier recommended. So I'll just skip this recommendation and come to the initial recommendation, about resuscitation, and just, summarize this. As I mentioned, the 30 mils recommendation using dynamic parameters, resuscitation using serum lactate, inclusion of capillary refill time, using crystalloids, a suggestion for using balanced instead of just normal saline, and suggest using albumin in patients who have received large volume, against the use of starch and against the use of gelatin. Again, norepinephrine to be the vasopressor of choice, and adding vasopressin especially when you have escalating dose of norepinephrine. Don't use it when as an absolute rescue towards the end, but when you see the norepinephrine doses going very high, very quickly, you should consider starting vasopressin, and also against use of terlipressin and levosimendan. And vasopressor, inotropic agents like dobutamine, only when there is septic shock and cardiac dysfunction after you've given fluid resuscitation. Other adjunct therapies have also been recommended, like corticosteroids, where you could give about 200 milligrams of corticosteroids, given 50 milligram intravenously every 6 hourly. And again, this is not a very strong, weak recommendation. Red blood cell transfusion, a more restrictive transfusion strategy, typically including hemoglobin concentration transfusion, to a trigger of about 7 of hemoglobin, stress answer prophylaxis. And for those patients who have risk factors for GI bleeding, they suggest using stress ulcer prophylaxis. Now, I just want to allude, and towards the end of my presentation, about equilibrating surviving sepsis guidelines with individualized care. So, the main thing that people have a problem with is the one-size-fits-all approach. They may not be very appropriate for all the patients, because we know we have different sepsis phenotypes. And this is a paper that we wrote on equilibrating surviving sepsis guideline and individualizing care in critical care. And I was very fortunate to be part of this group writing this editorial. And what is the rationale for an individualized approach? Now, you have a subset of patients who benefit from specific treatments, and we know they've not yet been identified. And the broad patient including criteria, this could lead to dilution of the positive findings by the non-responders to the positive effect in some patients, being offset by harm to the others. And that is the rationale for using an individualized approach. And the most severely ill patients usually suffer less from a single condition than from a complex physiological imbalance that defines specific disease definitions, and we know that. And management that strictly adheres to guidelines may not necessarily be the best approach in all contexts. It may be good when you have a unit where people are not very experienced and you need some kind of broad guideline, but it may not be good for people, especially when good expertise is available. It makes more sense to have an individualized approach. And the individual response to interventions must be closely monitored, depending on that response, whether the preset goal has been achieved. So this is the kind of rationale for moving towards an individualized goal. And we gave a set of 20 ways by which you could individualize the recommendations of the surviving sepsis guidelines. In the interest of time, I won't go through this, but I'll highlight a few important things, like the timing of ICU admission, okay, where they talk that within 6 hours, you should get the patient after diagnosis. So it could be ideally within minutes if a patient is severely ill, and can be less urgent in some cases. And in addition to this, you may have patients who are palliative, and not all patients need to be in the intensive care unit, and including the decision to admit patients. So they don't have any guidelines or recommendations of that. So many patients may develop sepsis at the end of their life, and patients with palliative care orders and treatment escalation plans that preclude advanced organ support should generally not be administered. So perhaps this is something where you could individualize the timing of admission and also the type of patients to the ICU. I've already talked about the initial fluid resuscitation. So you can't have a single formula applied to all patients. And this is really true for the 30 mils and within 3 hours. I think 3 hours is a very long period of time. And 30 ml as a bolus is a huge amount of bolus, and maybe too much in some patients and maybe too little in some patients. So we have to, have to fluid therapy using dynamic challenges, and the type of intravenous fluid is also important. For example, albumin administration can be considered in an intubated patient with profound hypoalbuminemia or prolonged non-response to crystalloids as well. In addition to say, the balanced crystalloids over the saline, it may be a little harsh to say that we shouldn't use normal saline. If you monitor the chloride levels, and you could administer the saline solutions in specific settings, and it's not that saline should be completely out, and we don't have any robust evidence to support that. The initiation of vasopressors. Now, this is really important because people go fluid, and despite that, if the blood pressure is not increased, then they start a vasopressor. But there are some settings where you might have to start vasopressor upfront. For example, if you have life-threatening hypotension, or in conditions where you have a very low diastolic pressure, something less than about 40 millimeters of mercury, these are very vasodilated patients, and you may consider giving vasopressors much earlier, probably co-administration with the fluids. And this is not very strongly recommended in the surviving sepsis guidelines, which probably need some modifications. And again, as I mentioned, the 65 mm is good as an initial target, but we may need higher or even lower target in different patients, and it perhaps is one of the recommendations that needs to be individualized. Administration of inotropic recommendation. Now, when tissue hypoperfusion relates to impaired cardiac function, the choice and the dose also of the inotropic agent should be based on individualization rather than a one-size-fits approach. Decision to administer corticosteroids, and not only in septic shock, but other conditions, as we've seen with COVID, maybe severe pneumonia. Now the new recommendations with pneumonia and also when ARDS might need it. And the thing that the guidelines do not actually tell you, which is essential and important, is involving a senior colleague or a consultant, especially since guidelines are most useful for non-experts. So teamwork, communication, and multidisciplinary teams are very essential aspects that need to be emphasized. And most importantly, the careful measuring and monitoring the effect of any therapeutic measures undertaking and deciding whether or not to continue and adjust the treatment accordingly. Now, these, I think, are very important when you consider an individualized approach. Now, I'll end by talking about resource-limited settings and specific considerations. We are working with a global team at the moment, looking at, trying to get consensus on what are the specific, things that are required for sepsis management in resource-limited settings. The Surviving Sepsis Guidelines does address a few aspects, but there are many things in resource-limited settings that perhaps need a little more guidance beyond what is given in the Surviving Sepsis Guidelines. And we may need alternative guidelines for resource-limited settings, or at least an all-encompassing, recommendation that also includes resource-limited limited settings. And I know the Surviving Sepsis Guidelines Committee is working on a special guideline on sepsis management in resource-limited settings. Also for diagnostics methods, and our next speaker is going to talk about this. And if you have a recommended pathology or test, some of these are not even available in resource-limited settings. Like I said, you may not have lactates, you may not be able to do the cultures very quickly, you may not be able to get the results very rapidly. So are you going to wait for all this to start antimicrobial therapy? So we need some alternate guidings for the diagnosis and also for the clinical management. For example, the medications, do we have all the antimicrobial agents? Are we able to give, do we readily have balanced solutions? Do we have all the equipment that is necessary? And also alternate strategies, if, staffing issues, not only staffing issues, also the expertise. And also considerations for transferring the patient to the ICU, not having adequate number of beds. And what are the safety measures that you need to take when you transfer someone, say, from a primary health center to an advanced center? So all these are specific considerations that we need in resource-limited settings, including alternate strategies to support the recovery of the patients. And we can't have a one set of guidelines that can only cover different situations in the developing world. We also need something that includes recommendations for the developing world. So I'll end my presentation by talking that sepsis is, of course, as you know, a major healthcare problem, and we need to emphasize and highlight this much more, like other conditions are, which get a lot of global attention because it is one of the largest, killers. Early identification and appropriate management in the initial hours improve outcomes, and every measure should be taken to do that. And that's what all the recommendations emphasize. Now, evidence-based guidelines, such as those in the Surviving Sepsis Guidelines, should be used as a basic guide, a good guide for management. It's really good to have. I'm not against guidelines, but you need something like this, especially in every unit, to fall back on. You have a trainee who's just joined your unit and they need to know how to manage this patient. You need guidelines for sure. However, the time may have come to move from this mass approach based on studies performed in heterogeneous populations to more tailored studies, because you have big, large randomized controlled trials showing no difference. So perhaps we need smaller studies, more tailored studies allowing integration, where you look at specific phenotypes, because what's happening in these big randomized controlled trials is that the benefit that is seen in one group of patients is getting offset by the harm that is seen in the other group of patients. And finally, we're showing no difference. So perhaps we need to look at specific phenotypes when we're designing our studies. And we need to embrace, diagnostic approaches using biomarkers perhaps in futures to identify those patients in whom the particular intervention is suited, and then to titrate the dose and duration. So this will probably be the future of sepsis management. And on that positive note, I leave you, and I thank you very much for your attention.
Thank you so much, ma'am, for so nicely setting up the context for today's masterclass and enriching our knowledge on the current practices and challenges being faced in critical care medicine. Thank you so much, ma'am. This gives me an opportunity to welcome our second speaker, Dr. Subhash Kumar Todi, sir. Sir has more than 40 years of experience in critical care medicine and is currently the Director of Critical Care and Emergency Medicine and the head of the Department of Academics and Health Research at AMRI Hospitals in Kolkata, India. I would like to welcome you, sir, and sir will be talking about the diagnosis and sepsis. Welcome, sir. You may please start your talk.
Thank you. Thank you, Dr. Gaurav. Can you see my slides and hear me okay?
Yes, sir. Your slides are visible, sir, and we can hear you.
Okay. So I think welcome to this sepsis webinar, a very important topic, as has been mentioned by Professor Maitra, and she had laid the stage for the entire sepsis campaign that has been going on all over the world. So my task today is to give you basically a practical approach to diagnosis of sepsis, which is sometimes really difficult. I do not have any conflict of interest. Early sepsis is difficult to diagnose, but easy to treat. Late sepsis is easy to diagnose but difficult to treat. As you know, this is so important adage that everybody should remember this. Everyone can diagnose late sepsis, but then it is too late. It is the early sepsis diagnosis that is the crux. And I think we all have to be very cognizant of this fact. The earlier we diagnose, the better for the patient. So my agenda today is I'm just going to touch on the sepsis definition, which has been already been elaborated, the screening for early sepsis, how to identify early organ dysfunction, little bit on capillary refill time, the lactate, the cultures, not only blood, but the other cultures, the imaging. I will touch on sepsis mimics, a little bit on tropical sepsis and non-bacterial sepsis. You know, the two keywords in this sepsis 3 definition is infection and organ dysfunction. And that is where the problem starts, in the sense that if sometimes infection is diagnosed by development of a new organ dysfunction. If anybody is developing newer hypoxia, then probably he is developing some infection. He might not be showing the other classical features of infection. And that becomes an issue. Organ dysfunction is both a feature of infection, and we also have an organ dysfunction. That's why it is called sepsis. So we have to have some criteria of diagnosing infection separately, which is sometimes not available in many patients. On the other hand, a patient might have an organ dysfunction due to some other reason. And he might be having heart failure, renal failure due to degenerative conditions, ischemic conditions. He develops an infection. Now he has infection, he has an established organ dysfunction, and that becomes an issue. So you see both the sides, and that creates a subjectivity in diagnosing infection. That was highlighted in this paper by Soffredini and Klompus. They gave this sepsis some case vignettes to experts, intensivists, senior consultants, and asked them to say whether it is SIRS, sepsis, severe sepsis, septic shock. I will just share one small vignette from this. They gave 6 vignettes. 67-year-old patient with severe ischemic cardiomyopathy, very low ejection fraction, now has come with cough and fever, have high heart rate, low blood pressure, high white count, rising creatinine. So he has some features of infection. He also has organ dysfunction. Now that organ dysfunction, he is in severe heart failure at the baseline. So you see, if you look at the case A, that was the case, there was a mix of response. Somebody said it's SIRS, somebody said it's sepsis, somebody says none of the above. It's a non-infective, the whole thing. And the reason when they were asked why they were thinking that it is not sepsis, it sounds like cardiogenic shock. There might be high white count, which meets SIRS criteria, but it's probably not infected. So that is the subjectivity which comes in the diagnosing of sepsis, which should be very clear whenever we approach a case of suspected infection and organ dysfunction. As was mentioned by Professor Sheila about the Surviving Sepsis campaign, screening a patient becomes a very, very important recommendation. And this is the first recommendation, because as we mentioned, detecting sepsis early is very, very important. So how do we screen the patient? So there are screening tools, but for each screening tool, we have to be aware, because different screening tools can be applied at different places. You know, there might be some screening tools are better for the emergency department, some for the ward, some for the ICU. Some screening tools have only clinical parameters, some also include lab parameters. They have differing sensitivity and specificities, and we have to know whether these tools are related to ultimate clinical outcome. So it's very important whenever we talk about screening tools, we need to keep these things in mind. I will tell you some of the screening tools which have already been mentioned by Professor Sheila. The first is by Roger Bone, this SIRS response, temperature, heart rate, respiratory rate of more than 20, and this white count. You see, this SIRS has both the infective markers and organ failure markers. That's why it is making a comeback again, probably, because some other tools are more of a prognostic tools rather than specific for sepsis. For example, the QSOFA. The QSOFA contains is of hypotension, altered mental status, and tachypnea. This can occur, for any patient, whether they are septic or not. They are definitely have got prognostic ramification. Patients having all these three, two or more of this will have bad prognosis. The other thing, which is, I think it is just a note to have a respiratory rate of 22. You might wonder from where this rate 22 has come. There is no scientific basis behind this number. The reason of 22 is, if you look back into the SIRS criteria, it was 20. 20 is the default respiratory rate, which is written by nursing and other people all over the world. So the reason of 22 is so that people count respiratory rate, because this is probably the most sensitive marker of very early sepsis, because sepsis produces increased minute ventilation, there is increased metabolic demand, so respiratory rate goes up. So very, very important. So this 22 is there so that people, when you think of 22, then you have to count. And that's why this 22 has come. Now this SOFA criteria, which have 6 organ dysfunction criteria, and they are ranked, they have been used. Initially, it was called as sepsis organ failure, but now it is sequential organ failure, because this can be used in non-septic conditions as well. Then this is the NEWS, the National Early Warning Score. Again, these are more of a early warning, not only of sepsis, but also of non-septic conditions, and this modified early warning score. Now, there has been an update on SOFA. Professor Maitra was also a part of this as well. So what are the problems with the current SOFA? For example, you require bilirubin, which might not be available immediately. So just clinical assessment of jaundice. PF ratio, you need a blood gas for that. So can we use an SpO2 FiO2 ratio? It says respiratory support. When initial SOFA was done, high flow was not that common. The ECMO was not that common. So these things need to be included. The vasopressors were only norepinephrine and dopamine, and now we don't use dopamine. There are many other newer vasopressors coming up. So these are the things which are important. So probably the newer version of SOFA might become a little more bedside oriented early, so that early detection of sepsis can be made. And GCS, for example, it has to be without sedation. So the QSOFA is a predictor of poor outcome. It is a prognostic marker. And when it was initially decided, it was not decided to be used as a screening tool. It is more specific but less sensitive than SIRS criteria in detecting sepsis. Only 24% of infected patients had a QSOFA score of 2 or 3, but they had 70% of them had a very poor outcome. But one have to understand, none of these screening tools, SIRS, QSOFA, NEWS, MUSE, they are not sacrosanct. You require a bedside clinician, as I mentioned, when you give that case vignettes. Even the very expert clinicians were not very sure. So I think it is not only, it is the experience of the physician also, and having a very clinical acumen, and one needs to look at the patient very carefully. Yes, these are guiding tools, of course, and these are also good research tools, but clinical diagnosis of sepsis is also equally important. So in this iteration of surviving sepsis, they have recommended against QSOFA compared with SIRS and the other early warning scores. So I think SIRS is making a little comeback. Professor Maitra mentioned about this capillary refill time, which is again a very early warning, you might say, features of early sepsis and organ dysfunction, because as you know, whenever there is a organ hypoperfusion, the capillary refill time is increased, because that is something our peripheral circulation gets constricted first, then only the vital organ starts failing. And one of the tricks of, I have asked my fellows and other, how do they time? How do they time this capillary refill time? Because carrying a watch and looking at the capillary refill time at the same time becomes a little difficult. So it is like timing your CPR. You don't carry a watch while doing the chest compression, but you count one in 100, 2 in 100, 3 in 100, something like that. And you kind of time yourself and you know what is the capillary refill time. This was mentioned, so I won't go about it. Capillary refill time is as good as lactate or even better to predict organ perfusion, though mortality difference was not shown, but it is there in the surviving sepsis campaign now. Mottling score is another one, but it is difficult probably in the darker skin to score the skin hypoperfusion by mottling. The skin to core, the core to peripheral temperature, which is not used, it is used more in pediatrics, but again, a very good marker of very early feature of organ hypoperfusion. This was a work done by Mervyn Singer, where again, looking at the facial expression, can one have detection of something going wrong in the patient? And I think with experience, clinicians gradually get into this, that just by looking at the patient one and looking at the facial expressions of the patient, one can have some idea about whether he is deteriorating. So very early determination when the vital signs, the hypotension, the shocks and the acidosis, these are not there, but impending. So can we rely on these kind of things? 1 hour sepsis bundle, one has to measure lactate, obtain blood culture, administer broad spectrum, start fluid resuscitation, and vasopressor. Septic shock, has been mentioned, requires vasopressors and a serum lactate. It was or earlier, but it's a serum lactate, because then the mortality is in excess of 40%. But this is something which needs to be looked at. The definition says, despite adequate volume resuscitation, and then you add a vasopressor. But now we add vasopressors much early. Patient hasn't had time for entire volume resuscitation. So will the septic shock will be called whenever the vasopressor is started, which is started very early in many patients nowadays. So that needs to be looked into. Now, lactate screening tool for sepsis, this is the cutoff. It is neither sensitive nor specific to rule in or rule out. Again, it's a non-specific marker. This lactate can go up in any anaerobic condition, in any hypoperfusion condition. It is not available in many resource-limited settings. Probably metabolic acidosis might replace lactate in some of these settings. So lactate should be done. And clearance of lactate, in the sense that the lactate needs to be repeated to see whether it is coming down. But the problem with this is how frequently to measure. What is a reasonable decline? It's not very clear. And lactate comes down very fast earlier, but then there is a very slow decline. Guide to fluid and vasopressor resuscitation based on lactate decline is not very clear. One cannot continue resuscitation till lactate normalizes, otherwise it will lead to over-resuscitation. And there is a clinical lactate discordant, and there are a utility probably of other markers of hypoperfusion. Looking at blood culture, now blood culture is very important. We have an ID expert who will be talking after me. Blood culture is taking, because this is a sterile culture, most of the pathogens which grow from this, apart from probably staph epi, is a pathogen, whereas the other specimens we are not very sure whether it is a colonizer or a pathogen. The skin needs to be cleaned very properly. There has to be a separate venipuncture. There is a tendency sometimes to draw blood culture from the first intravenous needle which goes in for intravenous infusion. That should be avoided. There has to be separate venipuncture for blood cultures and 2 sets of blood culture, that is 4 bottles, ideally should be sent, which becomes costly, but that is gives the best yield. 2 aerobics and 2 anaerobics. And the bottles have to be filled up adequately by adequate amount of fluid, and it has to be labeled. Very important. Labeling is very important. When was it drawn? Which hand, which bottle has been drawn? So it's very important. This thing has to be taken care of. Another thing which has come into the campaign guideline is, especially in our setting, sometimes we don't have this blood cultures bottle ready. So can we wait till we get the cultures and then start antibiotics? One can wait till, they say 45 minutes. Why 45? The reason of 45 is if you wait for an hour, then there is a delay in giving antibiotics. So after 45 minutes, if the blood culture bottles are not there, you have to start antibiotics to be within that hour. And that's why the time 45 minutes have come. As was mentioned by Professor Sheila, in septic shock and very high probability of sepsis, yes, surely we should give antibiotic within 1 hour. Otherwise, we should investigate if patient is stable, and the time period could be 3 hours. Now, this question was, there is not a very robust evidence before to know whether we can give antibiotic after the culture. What happens? What happens to the blood culture yield if one gives an antibiotic after the culture? This was published in Annals of Internal Medicine, a very neat experiment where they looked at 300 odd patients who had a blood culture sent prior to antibiotic, and the blood culture was repeated at an average of an hour after the antibiotic, and the yield decreased from 30% to 19%, in the sense that if the blood was not drawn prior to antibiotic, the yield would have been only 19%. So it's very important that, so this was proven for the first time in this kind of a study, that blood culture should be drawn prior to giving antibiotics. What about the other cultures? One should send the sputum, not the saliva, the urine, the pus. And, many of the places, the labs are not open 24/7. This can be kept in the refrigerator overnight and can be sent next day to the lab. This should not be sent, just a swab or a tip of the Foley's catheter or urine from the urinary bag or a drain which has been put in there for more than 24 hours. They are full with colonizers and contaminants. So these are the specimens which need to be avoided. What about imaging? Yes, we have to do imaging early. We have to get an X-ray if necessary, and a straight X-ray abdomen, and a soft tissue, which sometimes can give and show us gas in the soft tissue in a gas gangrene patients. Look at the CT or MRI of brain, look at collection in abdomen, or look at brain abscesses. So imaging becomes a very important. Now, this is a tool which is being used more and more, is the focused ultrasound. Starting in a septic patient, one can look at the heart, one can look at the kidneys, the musculoskeletal, the liver, the procedures, and the source control. There are so many utility of basically a focused approach to sepsis ultrasound. So I think this is going to pick up, and nowadays ultrasound is available more and more in many places. So this should be utilized more often. So now coming to sepsis mimics. So I have gone through the different diagnostic approaches to early diagnosis of sepsis. But all that wheeze is not asthma. So sepsis mimics. Let me give you few examples. A 40-year-old lady presented with fever and right leg swelling. She is hypoxic, bilateral lung infiltrate. She has thrombocytopenia, prolonged prothrombin time. She has a history of lupus, and venous Doppler shows right leg popliteal thrombus. And she has an APLA syndrome. She was positive for. And so if you look at it, she has fever, she has hematological dysfunction, she has lung dysfunction. So by definition, she had infection with organ dysfunction. But this is not sepsis. She doesn't have infection. She has fever with organ dysfunction, which fever looks like an infection, but this was a non-infective condition. A 50-year-old male presented with fever, headache, developed seizure in the ER, had a low urine output, rising urea, petechial rash, anemia, thrombocytopenia, fragmented RBC in the peripheral smear, and he was started on clopidogrel a few days back. So again, you have fever, you have organ dysfunctions, and this is TTP. It meets all the criteria, all the 6 criteria of TTP. So again, they mimic sepsis, but this is not sepsis. Long-standing rheumatoid arthritis presented with fever and jaundice, anemia, leukopenia, thrombocytopenia, very low fibrinogen, very high ferritin, and the bone marrow shows plenty of hemophagocytes. And this is macrophage activation syndrome. Again, this patient has fever and features of multi-organ dysfunction, but doesn't turn out to be infective. It turned out to be macrophage activation syndrome. These are the one which gets very confusing because initially they all are suspected to be sepsis, but they are non-septic conditions. 60-year-old male patient suffering from psoriasis, have a very swollen right knee, very high white count, CRP, uric acid is also very high. And this is acute gout. We do miss, I have patients who have been started on antibiotics, then it turned out they have an acute gouty arthritis. This is a patient presented with fever, with rash, again, lung infiltrates, high white count, but this time with eosinophilia. Started on Bactrim, and this is DRESS syndrome. So this patient has eosinophilia with skin rash. So it's very important. So these sepsis mimics, similarly, there are a few other sepsis mimics which needs to be kept into mind. So whenever we approach a sepsis patient, always think, could it be a non-infective condition if the things are not fitting in? Tropical sepsis, we all know, I won't dwell into it too long. A 40-year male with fever, confusional state, has liver dysfunction. So this patient has liver dysfunction and confusional state. So 2-organ dysfunction with fever. So this is also sepsis by definition, yes, but this sepsis is typhus. Fever, patient with yellow discoloration, subconjunctival hemorrhage, thrombocytopenia, rising urea creatinine, again a sepsis, but leptospirosis. A patient with fever, with rash, with pleural effusion, pancytopenia, very classical rash of dengue fever. As you can see, there are clearing in between the rashes, very classical for dengue fever. Patients presenting with fever, chill and rigor, rising bilirubin, lung infiltrate, has falciparum. So again, these are all tropical sepsis, not a classical bacterial sepsis that we talk about. The Surviving Sepsis campaign is mainly geared towards a bacterial sepsis, but these are the things which needs to also be addressed. A 40-year-old male, these are some other sepsis by some other organisms, has an alcoholism, fever, right upper quadrant pain, hypoxia, right liver abscess. This is rare, but they have trophozoites of amoeba in the liver aspirate, and this is amoebic liver. So parasitic, another parasitic infection. We have a patient now in our ICU with pure red cell aplasia, was being treated with cyclosporin and steroids, had headache, hyponatremia, thrombocytopenia, raised LFT, CSF showed positive India ink with a lot of yeast, and cryptococcal antigen was positive. So cryptococcal meningitis. So it is again a fungal sepsis. So you can have parasitic sepsis, you can have fungal sepsis. A 60-year-old male COPD presenting with fever, respiratory distress, bilateral lung infiltrate, again liver dysfunction. So organ dysfunction, fever with an infection, but this time it is AB being positive. So this is tuberculosis. So tubercular sepsis, you see, they have all presented acutely. It's not a 3 months, 6 months history, very acute presentation. And this was very common: fever, respiratory distress, bilateral ground glass opacities, high CRP, low WBC, and this is COVID sepsis. So viral sepsis, the viral sepsis, the parasitic sepsis, the fungal sepsis, the tubercular sepsis. So this is very important. So sepsis is a syndrome, it's not a disease. The syndrome needs to be identified. Yes, we need to, by this organ dysfunction, we need to start resuscitative and supportive management, as was mentioned by Professor Sheila, but we won't change the outcome until the underlying disease, which is an infection of any etiology, needs to be identified very rapidly, which will be covered by Professor Ram. Empirical therapy needs to be started in many cases for the presumptive pathogen, not always bacteria. And the outcome will depend on identifying and treating the cause of sepsis along with source control. So I would finish here, and these are the things that I've covered: the definition, screening, early dysfunction features, capillary refill time, lactate, cultures, imaging in early sepsis. I discussed a little bit about sepsis mimics, tropical sepsis, and non-bacterial causes of sepsis. Thank you.
Thank you so much, sir, for such a detailed session and sharing so many clinical cases with us. I can see a very good audience joining us. And at this juncture, I would like to again thank our sponsor, Pfizer, for really going out of their way to promote this educational initiative by the British Medical Journal and always supporting our educational endeavors. A very important announcement for the participants: you are requested to please refresh your screen at the end of the session so that you will be able to download your certificates. Now, without further ado, I would like to now welcome our third speaker, who needs no introduction, Dr. Ram Gopal Krishnan, sir. Sir is one of the top leading infectious disease physicians and consultants of the country, currently practicing at Apollo Hospital, Chennai. Sir, I would like to welcome you to please take this next session on the role of rapid diagnostic and antibiotic approach in sepsis. Welcome, sir.
Thank you very much. I hope my slides are visible and I'm audible to all. Thank you for this invitation. This is the topic I've been assigned to. Two eminent speakers have gone before me and they have covered some of what I was going to say. So I will skip those parts relatively quickly. These are my disclosures. We'll start off with a basic case. This is a 27-year-old female who presents with abdominal pain and fever for 1 week. There was no response to empiric ciprofloxacin for presumed typhoid. This patient was somewhat hemodynamically unstable. There was tachycardia, tachypnea, hypotension, as well as hypoxemia, and the right lower quadrant was tender. A CT abdomen showed a retrocecal abscess with free fluid in the pelvis, and the surgeon has tossed this onto the physician's treatment. You want to treat medically for now, not go in and operate. So this patient was started on imipenem. The abscess was drained under CT guidance the same day. So an intervention was done, but not an open surgical intervention. The pus grew E. coli, which was an ESBL producer. It was sensitive to cefoperazone, sulbactam, and carbapenems, and the patient improved slowly over time. So this is a very typical bread and butter, community-acquired sepsis type of presentation who did well with a combination of antimicrobials and source reduction. This is the general slide, which I'm fond of projecting. Many of you may be trained in neurology, and neurologists always say that if you want to make a neurological diagnosis, you identify where is the lesion, where in the neuraxis. Similarly, in ID, it is essential to identify the syndrome. And if you can do that, sometimes you don't even need to know the microbial etiology. We all know that the commonest cause of community-acquired pneumonia is pneumococcus. So whether you grow it or not, you can treat for pneumococcus. The response to a fever is an evaluation, not antibiotics. You won't get anywhere unless you know what is going on. Dr. Todi said that you can be very severely ill, but that doesn't mean you have to be febrile. You could be afebrile, you could even be hypothermic. So don't put all your money on the temperature of that patient. Get all your blood cultures before starting antibiotics. He showed you one study, and this is a more recent study, which showed that there's about a 23% drop in people who already got antibiotics. He showed you the other study. So your blood culture positivity falls off by 10 to 20% if you give your antibiotic before that first dose. So always start your antibiotics after drawing your blood cultures. Dr. Todi spoke to you about blood cultures. I call blood cultures music. You want to hear music. You don't want noise from Foley catheter tips, drain cultures, etc. And the correct number of blood cultures to be drawn is a minimum of 2 and preferably 3. I always say your patient won't do well unless they're somewhat anemic from the blood culture volume that you draw from them, because blood cultures really direct you towards the pathogen diagnosis as well as antimicrobial susceptibilities, which are critical in this day and age. Another important point is you can't wait for the printed report on a blood culture to come back to you. This should be placed into an instrument overnight. So it's essential to do this so that when you come for rounds the next morning, your blood culture flags. That's music to your ears. And you have to know as soon as it flags. You have to communicate closely with the microbiology laboratory. In this study, the time to first dose of appropriate antibiotic, we all know that should be less than 1 hour, decreased from 9 hours to 1 hour if you actively followed your blood cultures, liaised with the lab. Either the lab calls you or you call the lab. You can't wait for printed reports here. This is an old slide. We know all this, that if you give the wrong antibiotic, for instance, you give penicillin for a gram-negative antibiotic, gram-negative infection, your patient is going to die. And repeated studies over the years have shown this. Similarly, this study, a more recent study, showed exactly the same thing. If you give the wrong antibiotic empirically, so on day 0, when the patient presents to you, you will most likely end up with a poor outcome. So it's essential to get your initial empiric therapy right, because we know that cultures take 48 hours. These guidelines have been discussed extensively. This was also mentioned. If the patient is shocky, start within an hour. Not shocky, say within 3 hours or so. And what antibiotic? Please don't hold your breath. There is no magic bullet which covers all the pathogens and which covers all syndromes. So if you identify the syndrome, for instance, if you say community-acquired bacterial meningitis syndrome, you know it's going to be pneumococcus, it may be H. flu, it may be a Neisseria, it may be listeria in an elderly patient. So you can often predict the etiology. And the second part of the puzzle in picking your antibiotic is to know what is going on in your state, in your city, and preferably in your own hospital. But as a general rule, when you look at hospitals all over India, if you have a severely ill patient from the community, you certainly should cover Enterobacteriaceae, including ESBL producers. I showed you that case. Pseudomonas as well, because that's traditionally the most virulent gram-negative pathogen. And unfortunately, and sadly, in certain situations, even carbapenem-resistant organisms, those patients who've been exposed to carbapenems in other hospitals are candidates for initial empiric coverage. If you have soft tissue syndromes or pneumonia syndromes, you need to cover Staph aureus, including MRSA as well. And if you have an abdominal syndrome, you need to use an antibiotic which covers enterococcus. This is not mandatory in all situations, but certainly in intra-abdominal infections, you may want to consider this. So you need to pick something which covers your gram-negatives. That is classically an anti-pseudomonal carbapenems. Carbapenems are the most bactericidal drugs which are reliably effective against ESBL producers. They cover Pseudomonas as well. So that would be the choice of most of us for community-acquired coverage. If your patient is less sick and you are relatively sure you are not dealing with a bacteremia, which is not the case with most patients with ICU sepsis, you could use a BL-BLI like Piptaz or Cefosol. On the other hand, in terms of gram-positive coverage, we are kind of spoiled for choice. We have a number of antibiotics, Vanco, Tyco, daptomycin, linezolid, clindamycin. The last two would be appropriate for soft tissue infection syndromes. So this is what the guidelines say. They say they do recommend coverage for MRSA in patients who are at septic shock or in those at high risk for MRSA, not needed if your risk is low. And how do you say somebody is at high risk for MRSA when they come in? If they had an MRSA infection earlier, that's easy, or if they've been infected or colonized earlier, if they've had a lot of antibiotic exposure, if they're on dialysis, or if they have recurrent soft tissue infections, these are all risk factors for MRSA empiric coverage. The guidelines also suggest that you use 2 antimicrobials for gram-negative coverage. Note that this is a weak recommendation based upon very low quality of evidence. And the main reason why they want you to do this is not for any fancy synergy or combination, etc. They're just hoping that one of your gram-negative coverage antibiotics will work. And once you know what's going on, you can discontinue the other agent. And this is also recommended for severely ill or shocky patients who may not give you much time to get your correct antibiotic on board. Once again, if your patient is relatively stable, you don't need it. If your patient has a confirmed infection, you don't need the second agent. This is how the literature is evolving. So who are the patients in whom you need more than one drug and perhaps coverage for multi-drug resistant or carbapenem resistant infections? These are patients who've been in and out of the hospital within the last year, immunocompromised patients, or if you're practicing in a setting where you see a lot of resistant organisms, say a tertiary level hospital as opposed to a primary level hospital, and travel to a highly endemic country. Well, all of you travel within India, which is highly endemic. So essentially, these guidelines would apply to any severely ill patient, antibiotic exposed patient whom you're seeing in an Indian practice setting. Source reduction is essential. We know that either surgical or radiologic source reduction is critical. No amount of antibiotics will fix an abscess. And this study clearly showed a reduced mortality if you got this done early with the least invasive method that is compatible with the clinical status of the patient. Now, many of our patients come to hospital for one issue and then develop sepsis. We all know that patients may come in with COVID, end up on the ventilator, and then develop hospital-acquired sepsis, which is quite a different ballgame in comparison to community-acquired sepsis. Here, not only do you need to cover the community pathogens that we spoke about, Pseudomonas and ESBL producers, Acinetobacter is an important consideration, as well as carbapenem-resistant organisms, which are really the soup of the day in most Indian ICUs. And certainly, if your differential diagnosis includes central line infection, then staphylococcal coverage is essential, including coverage for MRSA. So your number of organisms to cover includes increasingly resistant organisms. And this is not a complete list by any stretch of imagination. If you're practicing in a liver transplant ICU, you will even need to cover Enterococcus, perhaps even vancomycin-resistant Enterococcus. So it's really what kind of practice setting that you're in which determines what your empiric antibiotic coverage should be. This is a study, an all India study, which was published in Critical Care Medicine, where they looked at the epidemiology of organisms seen in Indian ICUs, and you can see these familiar players: Acinetobacter, Klebsiella, Pseudomonas, E. coli. Staph aureus was much less common compared to Western ICUs, and you can see that Candida creeps up on that list as well, especially in terms of catheter-associated bloodstream infections. So these are our familiar, the usual suspects when we talk about coverage for ICU infections. The second part of the puzzle is what is going on in your hospital. Now, this is my hospital, Apollo Hospital in Chennai, where I know my antimicrobials. For instance, I know that my MRSA rate is 31%. I know that 11% of my E. coli is carbapenem resistant. 30% of my Klebsiella is carbapenem resistant. So if I develop hospital-acquired sepsis, then I have to cover Klebsiella, and I can't miss 30% by just using a carbapenem. So I have to use something that covers carbapenem-resistant organisms. So this kind of knowledge is essential to have in your own ICU and needs to be periodically updated. And it's not just traditional antibiotics, even the newer antibiotics like, for instance, ceftazidime, avibactam, fosfomycin. You need to know what is going on with your CR, E. coli, etc. And you need to know so that you can pick your antibiotics upfront. This is critical in getting your first dose antibiotics, so-called first dose supremacy, correctly. So in the hospital, you have to use a much broader spectrum of antimicrobial coverage. We spoke about this for community-acquired infections. But in addition, all these drugs, tigecyclines, the polymyxins, either polymyxin B or polymyxin E, fosfomycin, ceftazidime, avibactam, with or without aztreonam, minocycline. Note that gram-positives, you're again spoiled for choice. The bugs are largely sensitive, so not a major issue at all. But gram-negatives, sometimes you may end up treating, you may end up with a very resistant infection for which you can barely get an appropriate antibiotic on board. So Dr. Thodi explained clearly that blood cultures are very important. You need to draw lots of cultures and make that patient anemic. But what happens when once the culture leaves the lab? Draw the blood, goes to the blood culture bottle, put into an instrument, and as soon as there is growth, it flags. The technician takes out a little bit of blood, stains it, calls it either gram-positive or gram-negative, and accordingly informs the clinician whether it's gram-positive or gram-negative, and then sets up identification and susceptibility testing through specific methods. But that's not all. In this day and age, we can do a lot more. Can you directly detect the organism from blood? Now, this is not yet ready for prime time. You may find several panels being advertised in India, but these are really not studied or validated, so not yet ready as of June 2023. Or you can identify what it is. You can put it in a MALDI-TOF machine, which will tell you exactly what it is the same day, or you can do a rapid gene identification. So this is kind of the protocol which I follow, or which is followed in my hospital. Draw blood, clinician tells you when it flags, you do a MALDI-TOF or a further test. We'll discuss this in a little bit. The same day, before you leave for the day, you need to know what organism there is. There's a big difference between treating, say, Pseudomonas and Stenotrophomonas. And again, a molecular test which will tell you if it's E. coli or Klebsiella, whether there is carbapenem resistance, so you can cover for resistance. Now, molecular diagnosis of bloodstream infections clearly saves life. This paper is fairly old, but they showed here that if you do 20 tests, you will actually save one life. And this obviously should be combined with stewardship. You can't wait for printed reports to show up on the patient's file the next day. You have to aggressively communicate this to the treating physician and get their response, escalation or de-escalation. So these are some of the techniques we follow, which are available and which we follow in our hospital. We do a MALDI-TOF directly from the blood culture bottle. In other words, blood culture GNB in the morning. By evening, the lab will tell you what the organism is. You can do any one of molecular panels. The one we use is the film array panel, but any of the others are appropriate. The CARBA-R panel was actually devised for use on a rectal swab, but we use it off-label for Enterobacteriaceae bacteremia. This is an abstract we presented a few years ago. This has been submitted for publication, looking at the expert CARBA-R for gram-negative bacteremia. We found that many of these patients were CARBA-R positive, so a lot of carbapenem resistance. And detection of the genes is very important, as we'll discuss in a minute. It's not enough to know that your patient has a carbapenem resistant infection. You need to know what the mechanism of resistance is, because the therapy is guided by the mechanism of resistance. So we actually escalated the antibiotic in 9% and de-escalated in 27% of patients. And this is kind of the flow chart in our hospital. If we know it's a non-fermenter, it's a little bit difficult to interpret these reports. But if we know it's E. coli or Klebsiella, and we know whether it's carbapenem resistant or sensitive, you can escalate or de-escalate accordingly. The blood culture identification panel is also done in our hospital. The main issue with this test is it's a lot more expensive, but look at the advantage here. You can see a number of bacteria are picked up, candida are picked up, a number of relevant antimicrobial genes are picked up, both in terms of gram-negative resistance and less useful for us gram-positive resistance mechanisms. The second part of the puzzle is, how does this matter? You may tell you, if I practice on an Indian ICU, if I'm using, if I see a carbapenem resistant organism, I would just reach for colistin or polymyxin. Well, you are slightly dated, if that is still your practice, because we know that when you compare colistin with ceftazidime avibactam, there are studies here. This is in a Western setting on KPC2 producers, which is largely a Western resistance mechanism. But it did show that your patient is less likely to die and much more likely to be discharged from the hospital well after starting treatment. So suggesting that you're better off using a non-polymyxin treatment. Polymyxins are dated drugs. They have a very low therapeutic index. The CLSI says that there's no such thing as a gram-negative sensitive to colistin. Even if it's exquisitely sensitive, they call it intermediate. This is version 1 of the IDSA guidelines. This has been updated very recently this year. And the European Society have also produced guidelines on how to treat these gram-negative resistant bacilli. And essentially, just to put a big volume of data together, they all suggest that you do molecular testing to detect which carbapenemase is present. And certainly in terms of Klebsiella, you are better off using this BLBLI. None of the other BLBLIs, the newer BLBLIs, are available in our country. This is the only one that's available in India. You need the ceftazidime avibactam to take care of the OXA48. If there is NDM1 as well, you add aztreonam, and 24 hours later, you get DST. I'll show this to you with a couple of cases, how this speeds up your appropriate antibiotic exposure. If your beta-lactam, say Cas-Avi, is sensitive, just go with that. If it's resistant, you will need to use combination therapy, usually polymyxin B-based therapy. Similarly, E. coli, but the important thing about E. coli is E. coli can be resistant to beta-lactams through a PBP4 insert, which is a penicillin binding protein which just does not allow the aztreonam to work. So your Cas-Avi plus aztreonam strategy falls short here. And therefore, you are often stuck with using either fosfomycin, which is actually a very good drug for E. coli, for CR E. coli, or stuck with polymyxins. So this is the approach towards severe, say, carbapenem-resistant E. coli bacteremia. This is what the guidelines currently recommend. So in terms of rapid diagnosis, you're really better off moving to the molecular lab. There are problems. This is costly, and you have to know the ID of the organism before interpreting. For instance, if you have a Pseudomonas bacteremia, there's no point looking for a carbapenemase gene, because Pseudomonas can kick antibiotic out of cells through efflux pumps. It can prevent antibiotics getting in through porin channel mutations. It has altered PBPs as well. So if it's a non-fermenter, Acinetobacter, Pseudomonas, carbapenemase testing doesn't help you, but it's very valuable for E. coli and Klebsiella. A resistance gene predicts exactly that, resistance, but not necessarily sensitivity. So this is an important point to remember. If you detect a resistance gene, yes, that particular drug won't work, but it doesn't mean that if you don't detect it, that'll work. It's important to realize this. Advantages are same-day information. This is very, very important in critically ill patients, immunocompromised patients, and perhaps to save cost, you could just do the Carba-R test, something like that, when you know there is Enterobacteriaceae. For instance, when you know that the syndrome is likely to be caused by E. coli, Klebsiella, say pyelonephritis, or after liver transplant. I'll show you a couple of cases in a minute to illustrate how this helps. So this is case 1. This is a 50-year-old male with CKD who just underwent a transplant, a renal transplant, and had a history of carbapenem-resistant infection 20 days after transplant, and presented with fever for 4 days with a slightly elevated serum creatinine. So this is not a patient in whom your nephrologist is going to be happy if you push colistin into this patient. It's highly likely that they won't talk to you after that. Well, what happened to this patient? The urine culture grew GNB, blood grows GNB as well. So you're clearly dealing with gram-negative sepsis. What do? You wait for sensitivities. This is what we did. We ran a test directly on the blood isolate, and this picked up an OXA48 resistance gene. And we know that ceftazidime avibactam works well against OXA48. So we started this the very same day. And for this resistance report to come back showing resistance to carbapenem, it took 48 hours. So you greatly speeded up your appropriate antibiotic therapy and thereby reduce mortality by doing a molecular test the same day as the day your infectious syndrome started. 72 hours later, we got the sensitivity to ceftazidime avibactam. And then the patient got better on a 14-day course. So a precious transplant patient's renal function was maintained or was stabilized by withholding polymyxins and a good outcome in sepsis. This is another outcome, another renal transplant patient who obviously gets a lot of powerful immunosuppressants as part of the transplant, including triple immunosuppression, and then came in on post-transplant day 5 with a fever syndrome. This patient obviously had a left shift. The creatinine was going up. Once again, very important not to give nephrotoxic drugs in this setting. The urine routine didn't show a lot of pus cells, but the urine culture grew GNB. The nephrologist started carbapenem, but when the blood cultures grew 4-on-4 GNB, they called for an ID consultation. We added fosfomycin because we know that this drug works very well for urosepsis, provided it is E. coli. And on that blood culture, the very same day it flagged at 8 p.m., we knew exactly what it was. We knew that this was an E. coli. We knew that this was an NDM1 producer. And obviously, that co-carries an ESBL gene. So you know, right? You know at the end of the day exactly what your organism is and what you need to target. So this is what we did. We did ceftazidime avibactam, which will be inactivated by NDM1 producers, and the aztreonam is effective against that, whereas the ceftazidime avibactam takes care of the ESBL production. The carbapenem was stopped. To get this printed report saying that everything is resistant, carbapenems are resistant, it takes 24 hours. And to get a sensitivity testing to the higher end antibiotics, it takes 48 hours. So you can't wait this long. You start your therapy and you do some kind of molecular test which guides your therapy. The the conventional micro lab can actually tell you whether this combination is effective or not by doing a double disc synergy test, which takes a long time for you to come back, 72 hours in short. So this was a patient with post-renal transplant graft pyelonephritis with E. coli bacteremia, which is carbapenem resistant, who successfully did well with a polymyxin sparing strategy. So this is my last slide in terms of the topic I've been assigned. Get 2 to 3 sets of blood cultures before starting antibiotics. Knowing what a patient is growing is really like music to your ears. You know exactly what your enemy is. If you're treating community-acquired sepsis, it's a fundamental error to use third-generation cephalosporins as well as quinolones, cotrimoxazole. ESBL producers are widespread in the community. You need to cover for them upfront. Carbapenem-resistant gram-negative bacteria have emerged in India and certainly need coverage for in all hospital-acquired infections. You have to know your local sensitivity data. If for some reason you don't have this, ICMR produces data. You can go to the ICMR website and look at your national sensitivity data to extrapolate your empiric antibiotic selection. Get a good history of antibiotic use because it's very simple. If you've been on an antibiotic earlier and you develop sepsis later, there's a high chance that that you are going to be resistant to that particular antibiotic and you are at risk for a multi-drug resistant organism. Start broad-spectrum antibiotics within an hour after drawing your blood cultures. And if your blood cultures flag, please use molecular testing. These tests are available in many labs across India. They should really be done by all hospitals that take care of sick patients whenever there is bacteremia to speed up appropriate antibiotic selection. This is my last slide. If you want to know much more in detail, you're just a week off from our annual conference. Please attend many sessions on sepsis, gram-negative infections at this annual conference. Thank you very much. I will stop sharing my screen right here and hand this back to Gaurav.
Thank you so much, sir, for such a detailed session. I would now request Professor Sheila Mehta, ma'am, to please take over the panel discussion.
Thank you very much, Dr. Gaurav. That was an excellent presentation, Dr. Ram and also Dr. Todi. So, and we are in a very good time because I see we are perfect. It's 8 o'clock, it's just 8:01. And there are lots of questions that have come in. So I'll start with you, Dr. Ram. The first question is, what is your approach to antibiotic de-escalation and discontinuation? How do you do it?
So de-escalation refers to narrowing the antibiotic spectrum once you know your organism and sensitivities. There are two things you need to have before you de-escalate. Number one, the patient is more important than the culture report. Your patient should be clinically stable. Number two, cut it down to the narrowest and cheapest antibiotic that does the job. And that can be done as early as 48 to 72 hours. If the gut is working, oral therapy is appropriate. If the gut is not working for some reason, parenteral therapy. So at 72 hours max, you need to reevaluate whether your patient can come off broad spectrum antibiotics and go to a narrow spectrum antibiotic. That can only be done if your culture is flat. Discontinuation of antibiotics is more of a clinical call, often in non-infectious syndrome, some of which Dr. Todi pointed out. You got to have a good clinical acumen and a little bit of guts as well to say, my patient has, say, tumor lysis syndrome, okay, after CAR T cell therapy. My patient does not have sepsis, stop the antibiotic. So that is more a clinical judgment call.
Right. So just to take this forward, what about the role of procalcitonin? Would you use that to start or even to discontinue antibiotics? And what are your cutoff values and how do you use it in clinical practice?
I'm sure Dr. Todi would add to this. Personally, I draw the baseline procalcitonin, but I don't even look at the report. I just need a baseline. And then I redo it at, say, 48 hours. That tells me a trend in sepsis. I rarely use procalcitonin to diagnose sepsis because we know that the sensitivity, specificity are 75, but it's useful as a follow-up measure. Where I find it most useful is in culture negative sepsis or in non-infectious syndromes, say acute pancreatitis, which mimics sepsis. A falling procalcitonin can convince people to stop antibiotics, and whatever is going on is getting better. Dr. Todi, I'm sure would want to add to that.
Yeah, either of you could take this. So generally when you see very low values, less than 0.5, and your patient's clinically better, would you just stop the antibiotic, Dr. Todi? Or even if the patient is still, say, having clinical signs of sepsis, but the value of procalcitonin is very low. So what
the procalcitonin came into practice when there was a long duration of antibiotics. If you have procalcitonin, instead of 14 days, you can cut it down to 7 days. But if you are giving it for 6-7 days, it becomes very difficult for procalcitonin to bring it down to 3 days. And that is where nowadays, I think this is one of the best de-escalation that we can do, because in our country, we don't have many options to de-escalate because, all ESBLs and NDM, what will you de-escalate to? So decreasing the duration of antibiotic, that is, I think, is the best once the patient clinically stabilized, if the source is under control. The only thing what we do not know is the short course of therapies mainly has come from non-MDR settings. What is in MDR settings, we still do not know. It might be short, it might be long. We are not very clear. But what I do is, if a patient is clinically stable, and we just stop antibiotics in about 5 to 7 days time, and very few of them will have relapse, very few of them. So I use less and less procal now, definitely not for diagnosis, even for de-escalation.
So I think that's very good points. You definitely wouldn't use procalcitonin to diagnose sepsis or even to start antimicrobial therapy, but perhaps you could use it in adjunct to support your decision to stop the antimicrobial, especially when the procalcitonin value is very high. So there's a question to you, Dr. Todi, that how do you just diagnose sepsis clinically? When do you say that this patient is septic, has sepsis?
It is somebody who's not looking well, and you think this patient is infected. I think these two, not looking well, as I mentioned, there have been studies by Mervyn Singer. And yes, we have to go by organ dysfunction, definitely. But the earlier we diagnose sepsis, the better. The SIRS criteria, I think the respiratory rate the hypotension, the confusional state, and not looking well becomes very important. So very early diagnosis. The only problem, as I mentioned, is new organ dysfunction sometimes is a marker of infection. So you do not have a separate marker of infection, and that is where diagnosing sepsis becomes a little difficult. So you have to have your clinical judgment and look at the patient.
And we all know when a patient is not looking fine. We all know how to diagnose that. The only downside is that we may land up overdiagnosing a bit of sepsis. Of course, our other investigations to support a diagnosis of infection. The other question, and I can take that, what is the ideal fluid of choice in sepsis? I would say there's no ideal fluid, but definitely we would use crystalloids over colloids. The Surviving Sepsis has recommended using balanced fluids over using, saline. And we have a lot of studies now, but not very conclusive and not very robust data. And it's also still controversial. What are your balanced solutions? So essentially, these balanced solutions, they are sodium based, but they have a chloride less than 154 millimoles per liter. And they have various buffers that are added in order to make their concentration more similar to plasma. But it's important to remember that balanced solutions also include Ringer's lactate and Hartmann solutions. So it's not that you have to only use plasma light and stereofundin. But again, you can't have an extreme view. It's not that you can't use normal saline and that normal saline is completely out and we throw it out of the window. The problem with during resuscitation using a lot of normal saline, as is done, was often practiced in the Western world, especially North America, was hypochloremic acidosis. So I think if it's reasonable to give some amount of saline, it's not that you just can't use saline, but you must monitor your chloride levels. So I think a balanced approach, definitely with crystalloids and using more of a balanced solution is the way forward. We use a lot of Ringer's lactate, but I also use saline in some patients. But the other approach is when you're seeing that the patient is requiring large amount of crystalloids and you know they have leaky capillaries, it's good to add on albumin to these patients along with giving crystallized patients. So that would be my approach.
Sheila, can I just mention the two recent studies, one from ANZIX and another from Brazil, have shown that balanced is as good as normal saline. So probably the next Surviving Sepsis might take the balanced crystalloid out as well.
I agree with you completely. That's why I said there's no robust data, and this is a big ongoing and fight. And even the recommendation by the Surviving Sepsis is a weak recommendation. It's not a strong recommendation. And that's why I said you cannot just say that saline is out, because some people get the message that now we have to use only crystalloids and only balanced crystalloids and no saline at all. My next question is multiplex PCR. Will they differentiate a colonizer from a pathogen, Dr. Todi?
Ram, you want to take it up? Multiplex PCR diagnostics.
Well, no, really. The differentiation between a colonizer and a true pathogen in blood culture depends upon several factors. Number one, does the patient have a clinical syndrome? Number two, what is the organism? As Dr. Todi mentioned, if you're growing coagulase negative staphylococcus, that's highly likely to be a contaminant. If you're growing E. coli or Klebsiella, that is surely going to be a pathogen. And finally, whether all bottles of two sets cultures flag or just a single bottle out of, say, 4 bottles flag. So the fewer the number of bottles that flag, the more likely this is to be the skin contaminant. So all these factors go into deciding whether it's a true bacteremia or a pseudobacteremia.
Right. Another question on antimicrobial agents is, what is the difference between cefeprazone sulbactam coverage versus piperazolone tazobactam? And when do you prefer one over the other? In what clinical settings? Cefeprazone sulbactam and piperazolone tazobactam.
They are both early generation BLBLIs. They are appropriate for less seriously ill patients who are unlikely or who don't have a bacteremia, for instance, ward sepsis or ward urosepsis. I don't have a personal preference for each over the other. Piptaz is US FDA approved, so it's there in all the textbooks. For instance, in your Sanford guide, you won't find cephosol there, but I would think they're essentially interchangeable.
And one more question on antimicrobials: that what are the new antibiotics, given that in sepsis, we have so much antimicrobial resistance. So what is in the pipeline? What is
Zero. The pipeline is dry. So that is an important take-home message for this audience. We are running out of antibiotics, and as soon as a new one comes, you bet that within a year or two, the bugs will become resistant. Just for discussion, there are two drugs called. One is called cefiderocol, which is US FDA approved. It may work against Acinetobacter, even against NDM1 E. coli, but already resistance is described. For Acinetobacter, there's a US FDA approved drug called sulbactam durlobactam. This is specific for Acinetobacter. Again, these drugs have yet to come to India. So right now you're stuck with whatever you have.
So this reinforces the importance of antimicrobial stewardship, antibiotic stewardship even more, right? Rather than waiting for any more drugs to come. There's another question on urosepsis. And what would be, the best antibiotic choice that you would use in patients with urosepsis?
For community-acquired urosepsis, your target pathogen is an ESBL producer. Very simply, if it's a critically ill patient in shock, I would give a carbapenem. If it's a less seriously ill patient who can go to the wards, a BLBLI like Piptaz or Cefosalb is appropriate.
Right. So there are lots and lots of questions. I'm just selecting a few, but and how? Okay, either of you could take it. How would you choose the antibiotics in culture-negative sepsis when clinically the patient is clearly looking like an infection, but it's culture-negative?
It's a syndromic approach, as Ram mentioned. Like for example, if it is a pneumonia, community-acquired, you have to cover pneumococci. If it is a meningitis, many a time we do not know the exact cause, but we know what are the 2 or 3 bugs causing it. Similarly, if it is a hospital acquired, if it is a VAP, like in my hospital, if it is a VAP, I have to cover Acinetobacter and Klebsiella. So I think it is a syndromic approach. So once you have that syndrome, you know which are the bugs and a reasonable idea of their susceptibility.
There's you want to add, Dr. Ram? Do you want to add to that?
That's fine.
Okay. So there's a specific question for you, Dr. Ram. They've asked why we didn't see TG cycline for gram-positive cover on your list. Your comments on this, please.
Yeah, TG cycline is appropriate if you don't have a bacteremia. If you have, say, a staphylococcal or a pneumococcal or an enterococcal bacteremia, TG cycline is a poor choice because intravascular levels are low. So it's appropriate for soft tissue syndromes. It is approved for soft tissue infections caused by gram-positives. So it's not a drug you could use upfront. At least you have to rule out a bacteremia before you use it. So it's perhaps an additional drug or a second drug which you could use not as a primary agent for a gram-positive infection.
Right. So there's a question on vasopressin. I think that I can take that, the dose of vasopressin in septic shock. So the dose is about 0.3 units per minute, but you could go up to 0.6. There are studies showing this, but then again, you have to be careful because it is associated with splanchnic digital cardiac ischemia. So you should avoid going up to higher doses. Now, how you could titrate this? Now, usually the vasopressor of choice should be norepinephrine. The current recommendations for using vasopressin is, especially when earlier we used to use norepinephrine, and when you still can't manage the blood, maintain the blood pressure with fluids, norepinephrine, then you would add on vasopressin. But now we would start it much earlier, especially when you would see a patient with rapidly escalating doses of norepinephrine. You start with a lower dose and you're going very high, or your patient is already on 0.2 to 0.5 microgram per kg per minute of norepinephrine. You could consider starting the vasopressin. So definitely a role for starting vasopressin earlier, and not only as a vasopressor, but there's also vasopressin depletion during sepsis, especially after the first 48 hours. And therefore, it makes sense to supplement in patients with septic shock. So that would be the role. There is a question on how your comments on adjusted IV drugs dilution. So decreased diluent amounts for administration. Can you comment on this? What is the impact on clinical outcome in patients? The diluents, So
the positive fluid balance is one of the biggest issue. Any patient with having a net cumulative balance have a poor outcome. Whether it is epiphenomena, we are not very sure. But one of the reason of cumulative balance, positive balance is one is we are giving too many fluids, but the second one is this diluent thing, because somebody is getting meropenem and any gram positive cover, it can land up having 700, 800 cc's in a day. So I think one needs to look at the package insert and see what is the minimum dilution that is allowed for that drug and use it. And especially in patient with renal failure and heart failure, that should routinely be done.
Right. So avoid excess of the diluent and
Yeah.
unless resulting in positive fluid balance. Yeah. So again, the question on what are balanced crystalloids, I think I've already answered them. And why should you monitor the chloride levels while infusing normal saline? Well, if you're just giving one bag of normal saline, you don't need to necessarily monitor the chloride levels. It's when you're using a lot of chloride, normal saline for resuscitation, then you should do it with caution and you should measure the chloride levels because we are concerned about hypochloremic acidosis. There's a question, B lines on ultrasound, how do we interpret them? And are these B lines helpful in pneumonia, to diagnose pneumonia?
Not for pneumonia. The B lines is a marker of interstitial fluids. So usually in heart failure. So if one is following a patient, it is also in ARDS. There are nowadays literature, can we differentiate B lines of ARDS from B lines of heart failure? One needs to look into the severity and the degree of B lines, how approximate they are, and also look at the pleura. In ARDS, the pleura is usually having a shaggy appearance, whereas in heart failure, they're very clean. So B lines are there in heart failure and in ARDS, but not specific for pneumonia. In pneumonia, you get a consolidation feature with or without dynamic air bronchogram.
Yeah, so I think these can support your diagnosis. It's not black and white, but they can be used as adjuncts. So the other question is antibiotic of choice for CRAB not responding to polymyxin-based therapy.
Well, first, reevaluate your diagnosis. Acinetobacter often is a colonizer, especially if grown from endotracheal secretions. On the other hand, if it's a true infection like a high-grade bacteremia, the drug of choice for Acinetobacter is not polymyxin B, it is sulbactam. This is very, very important. This is there in the guidelines. Your sulbactam therapy is your first therapy of choice, irrespective of sensitivity testing, and you always need a second agent with that. If polymyxins are sensitive, especially if the MIC is low, say 0.5 or lower, yes, you could use them. Other drugs that would work well are tigecycline and minocycline. Wait for darlobactam, sulbactam. Hopefully that will come to our country sometime, and perhaps cefiderocol, which is less good an answer. Acinetobacter is a problem pathogen in the ICU, really.
Just one more question for you. Can an in vitro carbapenem sensitive Enterobacter develop in vivo carbapenem resistance because of the presence of CRE genes in expert CARBA-R?
Yes, the recommendation is if you detect a gene encoding for resistance, you always cover for that irrespective of the sensitivity reports, because the gene is there, and often giving an antibiotic may select out those resistance organisms. So from a clinical standpoint, cover for a worst case resistance scenario. Treat those patients as if they are carbapenem resistant.
Right. Then there's a question on endpoints for fluid resuscitation. I think I can take that. So again, a lot of people give fluids just to optimize the blood pressure, and we still don't know what is the ideal blood pressure. As I mentioned in the surviving sepsis guidelines, just the initial target is 65. They don't say that you maintain 65. Some patients will need a higher MAP, especially patients who are hypertensive. So just targeting blood pressure is not enough. Your endpoint of resuscitation is to optimize the tissue oxygenation and perfusion. So rather than just look at upstream targets, you need to look at downstream parameters, like look at your lactates, look at your SCVO2, look at your capillary refill time that Dr. Todi alluded to. So these could improvements in this, improvement in urine output. Lactates, of course, there is a delay. It doesn't, lactate clearance takes time. So I would not say there's a single target that you should look at, but you should look at a conjunction of these. But essentially, you're looking at improvement in these clinical parameters and reversal of the organ dysfunction and improvement in that. So I think that should be your target of resuscitation, rather than just saying I'm going to normalize the lactate of this patient. Then there is a question, Dr. Todi, about how to use. I think I've covered most of the questions. What is the treatment regime to be used in sepsis-induced DIC? I know it's a little offbeat question, but
one need to treat the underlying cause. I think that's the most important thing, and not to add fuel to the fire. So, not to add FFPs and all that. That will increase the DIC problem. So rather treat the underlying disease.
Treat the sepsis, the cause of the sepsis. Yeah. Okay. What is the use of fungifast, Bactfast?
So these are molecular tests which are used to, I wouldn't say molecular tests, these are actually sequencing tests which you can use on sterile specimens in culture negative situations. For instance, it's a whole genome sequencing test. How this would help in severely ill patients, I am not clear. Where I use these tests are in situations which are culture negative. For instance, on a heart valve in a patient with endocarditis which has been excised, or a prosthetic joint whose cultures, in whom you suspected infection, but cultures are negative. So in severely ill patients, you go by your blood culture data, for which there is really no test available in India, despite what many commercial labs claim, for diagnosis of infection directly from blood. So really, these tests don't belong in an ICU, really.
Right. There's a question about how to avoid, intraoperative sepsis. Of course, it's multifactorial. Strict aseptic precautions have to be used by the surgeons and even the anesthesiologists and the entire team while doing procedures. And also reducing the time to surgery has some impact on, longer duration of surgery is associated with, more incidence of sepsis. So essentially just tightening whatever infection control measures you have intraoperatively will make a long, will help in reducing intraoperative sepsis. So I think we've covered most of the questions. We have about 6 minutes. Is there anything that you would like to discuss? Because we have a few minutes more of time. There's one question on, can you, some clarification on MIC in culture and sensitivity?
Yeah, so when you grow an organism, you will set up sensitivities for that, which the lab will report these as S, which means sensitive, R, which means resistant, and if it is somewhere in between, they call it I. So this is all the average clinician needs to know. Now, it turns out that even within the S range, there can be organisms which are very S, so to say. In other words, they have a low MIC, or maybe not so S, kind of at the borderline, which have a high MIC. And the organisms that in whom we worry about an MIC are the difficult to treat organisms. For instance, MRSA, we would want an MIC to vancomycin, because the approach to a patient with an MRSA vancomycin MIC of 2 is different from that with a vancomycin MIC of, say, 1. Similarly, if you have a colistin so-called sensitive infection, say a gram-negative, you would want to know whether that MIC is 0.5, which would tell you that polymyxins would work well, versus an MIC of, say, 1, which is very difficult to inhibit. The cutoff is 2. If it is 1, there's very, very little chance that you're going to have a drug level high enough above that MIC. The basic point is, the lower the MIC, the higher your drug gets above the MIC, and the greater the chance of a favorable therapeutic outcome. If your drug level is close to the MIC or just above, there is a higher chance of therapeutic failure.
Thank you. You've explained that really nicely. So there's one more question on how you would taper vasopressors. I can take that if a patient is on norepinephrine and vasopressin. Now, this is really a challenge, and there are no clear recommendation as to whether you should stop vasopressin first or norepinephrine first or taper, one or the other. There are, of course, fixed doses of vasopressin. I tend to usually stop vasopressin, but we don't have robust data for either. It's more a trial and error kind of thing. And this is some area where we do need more research and recommendation. But as of now, I mean, different people practice different things, but we don't have a clear recommendation on that. There's one more question, Dr. Todi, if I can ask you this. How would you interpret a procalcitonin value of 40 or say more than 100? Like, how do you interpret it?
Most likely it's a non-infective process, because sometimes we have seen with corrosive poisonings and others, patient can have a very high procalcitonin, and whenever there is a breach of endothelium and all, procalcitonin is made in endothelium. So whenever there is a breach in endothelium due to whatever reason, procal can go up. Certain tumors will have very high procalcitonin. So very high procalcitonin in a patient, who is not, not almost dying. Those are the ones who can have high procalcitonin, but most of the time I have found it's not infected.
Right. I think that's a very important point. So I think we've answered almost all the questions that have come. And I think, thank you very much, Dr. Todi and Dr. Ram, for giving such detailed explanations and answers to the questions and the comments that we've received. I'll just hand over to Dr. Gaurav Singh to end the session. Thank you very much.
Thank you, Sheila.
Thank you.
Thank you so much, ma'am. For me, I think this masterclass has been a complete package. I think the lectures have been very detailed, and thank you so much for such a nicely moderated Q&A session. I think this is what the audience comes for taking these insights that really improves their clinical practice. So thank you, ma'am. Thank you, Todi sir. Thank you, Ram sir. I would like to now thank Pfizer for supporting our initiative. And again, I would like to announce to the audience that please refresh your screen to get your certificates at the end of the masterclass, and do not forget to fill the feedback form. This really helps us to improve our future masterclasses. So thank you very much. Thank you, speakers. Thank you all.
Thank you. Thank you, Gaurav.
Thank
Thanks,
you.
Sheila.
Thank you.
Ram.
Bye-bye.
Thanks a lot.
Stay back for 1 minute, sir. We can just close the session.